Hello, my name is Ruby Maini, and I am a PGY3 in Internal Medicine from Southern Illinois University School of Medicine. Today, I would like to present to you a rare case of endocarditis associated with a C-ANCA vasculitis. Infective endocarditis is defined by an organism entering the bloodstream and attaching and growing on the lining of the heart and is usually diagnosed by using Duke's criteria. A thorough physical examination, labs, and blood cultures all play a role in diagnosing infective endocarditis. Skin findings can include Janeway lesions and Osler nodes. There are rare instances where infective endocarditis may be associated with skin necrosis indicative of a leukocytoclastic vasculitis. Here, we present a rare case of infective endocarditis associated with a C-ANCA vasculitis. Our patient is a 59-year-old male with a history of alcoholic cirrhosis of the liver, heart failure with mid-range ejection fraction, and sick sinus syndrome, with a permanent pacemaker who presented to the dermatology clinic for a new onset rash of 1 week. He reported having these new onset bloody blisters over his hands, feet, elbows, and knees that would often burn. He denied any fevers, chills, and night sweats. However, he did report a concerning 90-pound weight loss over the last year. On examination, his vitals appeared to be stable with a temperature of 36.5 degrees Celsius, blood pressure of 140 over 87 millimeters mercury, heart rate of 109 beats per minute, respiratory rate 16 breaths per minute, and an oxygen saturation of 98% on room air. He appeared cachectic and poorly groomed with poor dentation. Skin exam revealed hemorrhagic vesiculobullous rash on the hands and feet as well as elbows and knees. A grade 2 systolic murmur was heard over the left sternal border. He did not have any palpable lymphadenopathy. His abdominal exam was significant for distension concerning for ascites, but was otherwise non-contributory. The rest of his examination was unremarkable. To the left, we can see the images of the hands and the feet of the patient, demonstrating the vesiculobullous lesions. The patient underwent evaluation with a complete metabolic panel, complete blood count, shaved biopsies of the left ankle and left ring finger, a transthoracic echocardiogram, and blood cultures. Blood cultures resulted with a gram-positive cocci, and the patient was called with recommendations to be admitted to the hospital. At the time of admission, the patient remained vitally stable. He did have similar lesions of his hands and feet, however. Labs revealed a normocytic anemia with a hemoglobin of 8.7 grams per deciliter, a remarkable thrombocytopenia of 38,000 cells per microliter, and an acute kidney injury with a known baseline creatinine of 1.0. Hyponatremia with a sodium of 129 milliequivalents per liter. Throughout the course of his stay, shave biopsies returned with epidermal necrosis, perivascular and interstitial dermal neutrophilic infiltrate, which were concerning for vasculitis. Further workup for vasculitis was undertaken, including a urinalysis, urine toxicology, an ANCA panel, and a hepatitis panel. The pertinent results showed a C-ANCA PR3 antibody was positive with a titer of 1 to 160. The patient was started on vancomycin at 15 milligrams per kilogram every 12 hours. Transthoracic echocardiogram then returned with a left ventricular ejection fraction of 40 to 45%, diastolic dysfunction, and a 0.6 centimeter by 0.5 centimeter lesion over the mitral valve and thickening of the tricuspid valve. In Figure 1, we see a transthoracic echocardiogram with mitral and tricuspid nodularities that are concerning for vegetations, as is highlighted by the red circles. Likewise, the red circles in Figure 2 demonstrate a medium-sized mitral valve vegetation and large tricuspid valve vegetation in the transesophageal echocardiogram that was performed. The patient was also found to have a vegetation on his pacemaker lead in the right atrium. The patient was started on antibiotics for a diagnosis of infective endocarditis at this time. The patient was then discharged with the PICC line and scheduled for outpatient antibiotics. Unfortunately, he did not respond to antibiotics and required readmission to the hospital. The vasculitic lesions showed no signs of improvement. Subsequent electrophysiology and cardiothoracic team evaluations deemed the patient high risk for surgical evaluation and intervention. After a multidisciplinary discussion with the patient, he decided to pursue hospice care. Antineutrophilic cytoplasmic antibodies, or ANCA, are typically associated with a primary systemic vasculitis. ANCA have also been described in other conditions including infections, connective tissue disease, and drug-induced vasculitis. A retrospective study identified the prevalence and clinical course of ANCA positivity among patients with infective endocarditis. There were not found to be any statistical significance between ANCA positive and negative patients regarding age, sex, and comorbidities. However, patients who had ANCA positivity were found to have a more subacute course of endocarditis associated with weight loss and renal impairment. So let's contrast our case with those of others found in the literature. We bring to light a case report of a 57-year-old male with rapidly progressive glomerulonephritis and positive serology for C-ANCA, with a renal biopsy confirming focal and segmental glomerulonecrosis. After receiving corticosteroid therapy, the patient worsened, and due to concerns of infective endocarditis, a transthoracic echocardiogram was obtained, which did in fact reveal an aortic valve vegetation. And after the patient had received appropriate antibiotic therapy and valvular surgery, he improved. Another case report in which a patient had subacute bacterial endocarditis with C-ANCA vasculitis who required hemodialysis demonstrated that his renal function did not respond to appropriate antibiotics alone, and instead required corticosteroid therapy, which is counter to the previous case, as the patient worsened. Now, our case is similar to the second case described in the sense that our patient, despite appropriate antibiotic therapy, still continued to have multi-organ failure and deteriorate. The implications of the presence of C-ANCA in bacterial endocarditis is unclear. The infectious process may induce an immune-mediated damage to the vasculature and lead to a fulminant vasculitis if untreated. The learning points in this case are that C-ANCA vasculitis may be a unique manifestation of acute endocarditis. In these types of cases, antibiotics would effectively treat the patient. However, with progressive, untreated subacute endocarditis, C-ANCA vasculitis can also develop into a fulminant vasculitis requiring corticosteroid therapy. While classic findings of infective endocarditis using Duke's criteria are imperative to reaching a diagnosis, a broad range of differentials need to be considered early in the event a patient does not improve with antibiotics, for a patient's outcome may depend on how quickly a provider can recognize a need for change in management. These are the references used for this presentation, and I would like to thank you all for joining our presentation.